Good morning, everyone. Right, so excellent set of talks and very comprehensive talk by Dr. Bhupesh. So we sort of decided that to try and avoid an overlap, I won't be talking about all the surgical options in keratoconus. Bhupesh has covered quite a few. I'll be talking mainly about DALC because PK is something which, there are a lot of, it's fairly simple in that sense. So we'll move to DALC. And the first question is, why would you prefer to do a DALC in these cases? Of course, we know there's a very reduced graft rejection risk as compared to a penetrating keratoplasty. It has a great wound strength with, if you are well versed with it, then less risk of intraoperative complications. Of course, you can't have an expulsive and things like that. And a faster tapering of topical steroids, so the complications related to that is less. There are multiple indications for DALC, but of course here we are concentrating more on the ectasias, and those are the most common ones which we do. There are a few points which you have to keep in mind when doing planning the DALC, and this really has a very important impact on our outcomes. The first being, what is the pathology you're doing it for, because the sizing of the graft, the centration of the graft, all of it matters. The next is if there is a scarring, and it can be because you're doing it for a scar or a dystrophy, or the keratoconus itself may have a scar. It's important to assess the scar on the slit lamp, or if you have access to an anterior segment OCT, to assess that, because your planning and the type of technique you use for the DALC would change. Of course, you're looking at the size of involvement, whether it's centered, decentered, the status of the endothelium and the DM. Very, very important to differentiate between a hydrops from a non-hydrop scar, because your technique you use would again change, and I'll be discussing that. So there are a number of techniques that we have for DALC, the most popular being the big bubble technique, which was invented by Anwar and Takeman. And that's the one which is most commonly done. But of course, you get excellent results even with a good manual dissection, and we'll show that. The greatest thing about DALC, I think, is the fact that you don't really need too many new or unusual instruments in your OT. Most of the time, you can manage with everything which is available. And if you're familiar with doing the bubble with a 30-gauge needle, then you really need nothing. Probably the only thing which I think would be very, very important or useful for a person starting out in DALC is a good set of blunt tip scissors, because they are fairly invaluable, especially in the posterior dissection. Now, critical steps when we're talking about DALC is centration and marking and sizing. So include the entire cone to make sure. So if you can see the Fleischer's ring on the slit lamp, then try to get that into your entire diameter of trephination, because otherwise you can have some amount of ectasia from that cone because you left behind part of it. Avoid too much of decentration if it's a small trephination, because you can get an incomplete bubble. So just very briefly, a few steps. So we can use, for the trephination, you can use a handheld trephine or a suction trephine, it doesn't matter. But if you're using a handheld trephine, then you really need to go in with a guarded depth knife, because a key to whether you're, irrespective whether you're doing a manual DALC or a big bubble DALC, is a key is to try and get that trephination as deep as possible. So if you're doing a manual trephination, then go in with your guarded knife, depending on how thick your cornea is, and then you can do an anterior dissection of the stroma. In the technique I follow, I almost always debulk the anterior stroma before going in for the big bubble, but I know a lot of surgeons who would avoid this step completely, and it would depend. The exception to the rule is if you have a very, very thin cornea, say a 200 micron in the center, 250 micron, then avoid de-roofing the entire cornea, because then you'll not get the big bubble because there's too little stroma. So next is the big bubble. So you can use either a needle or a cannula for the big bubble, it doesn't matter. But if you're using a cannula, then you have to use something like a point dissector to make a small track. And here it is essential that you go in as deep as possible, because the cannula is a blunt tip cannula. It's not going to go in deeper than the plane you put it into. So you have to get your point dissector as deep as possible. And now we'll insert the cannula. The direction is usually central or mid-peripheral. People have shown that even if you inject in the periphery, you may get the bubble, but putting it in the mid-periphery is much more repeatable and reliable. And you can get the bubble fairly, almost always, if you just follow this. The depth, of course, would depend again on the technique. With the needle, you don't need to make a separate channel, but you do need to make sure that you're going in the mid-periphery. And here you don't want to go too deep, because you may get a perforation. The next step is releasing the bubble. So once we have the bubble, we now need to release and de-roof the posterior stroma. So a few things before that. Almost always do a paracentesis so that your eye is softer. This prevents an inadvertent cut or rupture of the DM endothelium complex as it moves up as you de-roof the bubble. Putting in an air bubble into the AC after you've done the paracentesis, and this kidney-shaped bubble that you see here is that air bubble. This, first of all, tells us that you have actually achieved a bubble, and that big bubble is pushing the air bubble in the AC to the periphery. So it helps us really, especially if there's a lot of emphysema. And the minute it moves to the center, as you'll see in this video, you'll know that the bubble has been deflated. This is the brave slash. And one very, very important thing with the brave slash, if you can see the direction of the side port blade, is that we are going horizontally into the bubble and upwards. Okay, so the chance of you actually touching the DM in this process, unlike earlier when we used to do a vertical slash, a horizontal slash makes it very, very safe. And I also use a viscoelastic on top of the point where I'm going to put in the bubble so that you can see the egress of air. These are blunt tip scissors, and it doesn't matter which ones you have. Have a micro scissors with a blunt tip, invaluable in your dissection of the posterior stroma. Go in bravely, nothing is going to happen. The tip is blunt, the edges are blunt. And the DM endothelium, because this is the pre-decimetic layer, because this is a type 1 bubble, and the pre-decimetic layer is incredibly strong. It really takes a lot to perforate it once you've got the type 1 big bubble. Okay, so you do a quadrant dissection of this and try to remove it in sections. And that is the glistening DM there and the air bubble inside the AC. And this is how you go ahead. Try to avoid leaving too much of a ledge at the periphery because that would affect your graft-host junction. So you need to get a nice vertical ledge at the periphery. Excuse me. So once you've done all of this, invariably you get great outcomes with talc. You do need to make sure that this patient doesn't have too much of VKC or other allergies because that would affect outcomes. Right? But there are always some glitches which can happen. One is, of course, especially when we are starting out, is not getting the bubble at all. You inject, you get a lot of emphysema into the stroma. This, simply put, is you're not deep enough. We're injecting into the stroma, and so you're just getting a little bit of emphysematous bubbles. So the initial trephination has to be deep, and I was discussing how you can go deeper. And if it's a cannula, you really have to make sure you're deep. If the air is coming backwards, then you're not going to get the bubbles. So come out and try in a different area. The air has to go forwards, and that's when you're going to get the bubble. This was a sign that I described. And if you look at the video which is coming out, those fine little spikes are telltale that you're going to get the bubble. And this happens when you're not really as deep as you actually should be. It's somewhere midway. But unlike, I said you shouldn't get too much emphysema, don't stop if you see those spikes. Keep injecting and you're going to get the bubble. And how is it different from the earlier one where you see you're just getting a spot of, clump of emphysema? There's no spikes there. You're not going to get a bubble. Even if you inject, you'll just become a total emphysema. Now, what if it's a scar like this? In these cases, I would suggest not to try for a big bubble. You see, it's a full thickness scar. And even though this is not a high drop scar, if we try for a big bubble here, there's a high chance of getting a type 2 bubble, which then leaves behind just the endothelium DM, which is a much, much more fragile layer, and you're likely to develop complications. So here you can go ahead and do a near decimates manual dissection, and you can see that there's very little residual stroma on the anterior segment OCT. And even though there was a scar residual, this patient is still going to do well in the long run because of the lower risk of rejections. We have shown that the outcomes of manual talc, if done well, versus a big bubble talc, even though there's not so much of a wow factor in the initial time period, in the long run really doesn't matter. If it's a post-hydrops eye that you have to do a talc, it does not mean that you go ahead and do a PK. You can still definitely get away with doing a talc as long as it's not a very, very large scar. But you need to know that it's a hydrops and not try for a bubble at all in these eyes. So your dissection has to start periphery, early away from where the hydrops area is, of course. You can try various techniques of manual dissection, which I'll just show. And when you're in the area of the hydrops, the old hydrops, avoid pulling the stroma too much. You need to be very gentle. Leave behind a little bit of stroma so that you don't have a break. And if you have a break also, it will usually be a small break which can be handled. So this is just to show how you can do a good manual dissection. So again, here I'm showing a suction trephination, which you've already measured and kept. And then you go in again, as long as you go in deep enough. So here I'm taking the point dissector to again go a little deeper. And then with the blunt tip scissors, now I've already got the plane. This is already a near decimase plane that you've got. And once you're that deep, the attachment of stroma to the lower stroma is quite loose, and you can almost peel it off. You can also do the groove and peel technique, which has been popularized by Dr. Rishi Swaroop, which is a very elegant technique where you spiral around. But in this technique, you just go directly deep and go to the area, keep peeling it off. You don't need to use anything. This is what I meant. When it's a very, last part where the hydrop scar was, you don't want to pull it too vigorously. So, contrary to what we would think, I'm using a sharp dissection here, but that's just to release the fibers. So just to show you that even if you've had a hydrops, you can, once it's healed up well, you can get good outcomes even with a DALC. And this patient, if you can see, there's a large fish mouth scar left behind after the hydrops has healed. But even then, clinically, they're going to do well. You can see the scar, but they visually do very well. Last bit, just to show what we do if we get a perforation. So this is a case of manual dissection. And sometimes we get a little over-enthusiastic and a little overconfident, or there's an area of scar which we haven't anticipated. And you're dissecting. So wherever possible, avoid using sharper instruments for these cases where there's a lot of irregular scarring. And you'll see that suddenly in the middle of this dissection, which seems to be going fairly smoother, there would be a perf. I also like to keep the dissection fairly dry, unlike how we dissect a PK, and that's the perforation there. And you can see the aqueous coming out. It doesn't matter, these are small microperforations. So if it's in the periphery, all you need to do is leave behind a small patch of the stroma, complete the dissection in the other areas, and then put your donor cornea. The last case I want to show, this was a case of macular dystrophy. And some things like this can also happen when, we're using a suction trephine, where suddenly you see the fluid coming in there, and the suction trephine has gone in a bit too deep. That's okay, doesn't matter, we'll still be doing a DALC. So you suture the area which has got perforated, and start your dissection from another area, put in air to keep it well formed, and you just start your dissection from a peripheral area. And as I will show you, you can get a nice plane of the dissection. So that's the bare DM endothelium complex pre-disseminate dissection, and you can get away with a great DALC even in these conditions. So DALC is not without its complications, but most of the time if we preempt them, we can manage it fairly well and you get great outcomes. So wherever possible, please try to do a DALC and avoid PK. So thank you very much for your patient listening.
Thank you, Dr. Sharon, for an excellent talk and beautiful video.